Hello friends, welcome back to my channel. Today in this video I'll talk about tetanus, a potentially fatal infectious disease caused by Clostridium tetani. Tetanus is characterized by severe muscle rigidity and spasm due to production of neurotoxins. Despite the availability of vaccines, it continues to pose a global health challenge. Today, we will explore its historical importance, current epidemiology, clinical features, diagnosis, treatment, and prevention. Coming to its historical importance, tetanus has been recognized since ancient times with descriptions found in early medical texts. In the 5th century BC, tetanus was described by Hippocrates. The bacterium Clostridium tetani was identified in the 19th century by Arthur Nicoller. A major breakthrough came in the 1920s with the development of the tetanus toxoid vaccine, which significantly reduced global incidence rates. This picture shows a significant decrease in tetanus deaths by age group between 1990 and 2017. What is the current epidemiology of tetanus? Tetanus primarily affects individuals who are unvaccinated or live in areas with poor healthcare infrastructure. According to World Health Organization, neonatal tetanus remains a serious problem in some developing regions, causing approximately 30,000 deaths annually. Additionally, outbreaks are more common in war zones, areas affected by natural disasters, and regions with low vaccination coverage. Clostridium tetani is a bacterium responsible for tetanus, a serious disease caused by its potent neurotoxin. The toxin produced is known as tetanospasmin, which interferes with the normal muscle relaxation, leading to severe spasms. There are several clinical forms of tetanus. First is generalized tetanus. This is the most common form, characterized by widespread muscle rigidity and spasms. Second is neonatal tetanus, which is a life-threatening condition in newborns due to infection of the umbilical stump. Third is the localized tetanus, which is a rarer form where symptoms are confined to the muscles near the site of infection. Clostridium tetani is an anaerobic, motile, gram-positive rod with oval, colorless, terminal spores giving the bacillus a tennis racket or drumstick appearance. The bacilli and its spores are found worldwide in soil, inanimate environment, animal feces, and human feces. The spores of tetanus can survive for years as they are resistant to various disinfectants and can withstand boiling for 20 minutes. The vegetative cells get easily inactivated and they are susceptible to several antibiotics like metronidazole and penicillin group. The toxin tetanospasmin is formed in vegetative cells and has a heavy chain of 100 kilodaltons that mediates binding and entry into the nerve cells, and a light chain of 50 kilodalton that blocks neurotransmitter release. Because of the widespread coverage of tetanus vaccination, tetanus is now restricted to sporadic cases in areas where soil is cultivated, rural areas, warm climates, during summer months, and mostly among males. Most cases of tetanus follow an acute injury, which may involve puncture wounds, lacerations, abrasions, or other forms of trauma. Tetanus can be acquired both indoors and outdoors, with activities such as farming and gardening posing particular risks. Interestingly, the injury causing tetanus may be so trivial that individuals might not seek medical attention, and sometimes no identifiable injury or portal of entry is found. Tetanus may also complicate chronic conditions such as skin ulcers, abscesses, and gangrene. Additionally, it is associated with various situations like burns, frostbite, middle ear infections, surgery, abortion, childbirth, body piercing, and drug abuse, especially practices like skin popping. Recurrent tetanus has also been reported in some cases. What about the pathogenesis of tetanus? Infection starts with the contamination of wound with spores of tetanus. Next stage is germination and toxin production. It happens only in low oxidation reduction potential environment that is provided by the devitalized tissue, foreign bodies, or active infection. Tetanus bacteria do not evoke inflammation, and it is important to note that the portal of entry has benign appearance because of this feature. The toxin is released in the wound and it binds to the peripheral motor neuron terminals and enters the axon. It is then transported to the nerve cell body in the brainstem and spinal cord via retrograde intraneuronal transport. The toxin then migrates across the synapse to presynaptic terminals and blocks the release of inhibitory neurotransmitters, glycine and GABA from vesicles. The firing rate of the motor neuron then increases, producing rigidity, spasms, and sympathetic hyperactivity. Recovery from tetanus then requires a sprouting of new nerve terminals. Clinical features. The incubation period for tetanus ranges from 3 to 21 days with an average of 7 to 10 days. The most common form is generalized tetanus, which presents with trismus or lockjaw, rhizus sardonicus, muscle rigidity, and painful spasms. Localized tetanus and cephalic tetanus are rarer but can be seen in specific cases. Neonatal tetanus caused by the umbilical stump infections is associated with high mortality rates. Patients can develop autonomic dysfunction and have labile or sustained hypertension, tachycardia, dysarrhythmia, hyperpyrexia, profuse sweating, peripheral vasoconstriction, increased plasma and urinary catecholamine levels. Patient can develop complications of tetanus that include aspiration pneumonia, fractures, muscle rupture, deep vein thrombophlebitis, pulmonary emboli, decubitus ulcer, and even rhabdomyolysis. Tetanus can be classified as mild with muscle rigidity and few or no muscle spasms. Moderate with trismus, dysphagia, rigidity, and spasm only. Severe tetanus is the one that has frequent explosive paroxysm of tetany. Coming to the diagnosis, tetanus is primarily a clinical diagnosis based on characteristic symptoms as there is no definitive lab test. A detailed history of a wound or injury combined with inadequate immunization can help in diagnosis. It is essential to rule out other conditions such as meningitis, strychnine poisoning, or hypocalcemia. Treatment of tetanus involves several key steps. First is the supportive care, which requires ICU admission, that is often necessary, and mechanical ventilation may be required in severe cases. Second is wound management. Surgical debridement helps remove necrotic tissue and prevent further toxin production. Third is antimicrobials. Metronidazole is the preferred antibiotic, though penicillin can also be used. Fourth is the toxin neutralization. Human tetanus immunoglobulin or TIG is administered to neutralize the circulating toxins. Fifth is the symptom control. Diazepam, baclofen, and magnesium sulfate can help reduce muscle spasms and rigidity. Coming to prevention. Prevention of tetanus is crucial and involves the routine immunization with the DTaP vaccine during childhood and booster doses every 10 years. Post-exposure prophylaxis. For clean minor wounds, a DTaP booster is required if more than 10 years have passed since the last dose. And for contaminated wounds, both DTaP and TIG should be given if the immunization status is unclear or incomplete. Maternal immunization reduces the risk of neonatal tetanus through passive immunity. Proper wound care with cleaning, debridement, and avoiding exposure to the contaminated environments are essential steps. To conclude, tetanus remains a preventable but significant global health issue, particularly in population with low vaccination coverage. Early recognition and aggressive treatment are critical in improving outcomes. Widespread immunization, maternal vaccination programs, and effective wound care are key public health measures in the fight against tetanus. Thank you for watching. Hope you liked it. Like, subscribe, share, and comment. Do not forget to press the bell icon to receive notification of all such new videos.